There is a lot of background noise.
It means embracing
Okay,
the heart health
one moment.
lifestyle. It means
Now it's
quitting
okay, sir.
smoking and limiting alcohol
No, no,
consumption,
still there is background noise.
showing empathy and kindness, which can reduce stress and promote overall heart health. It means being there for our loved ones, encouraging NECG Medical College and Hospital, Maharashtra. P. Jayanta Kumar, consultant
Good
cardiologist.
evening and welcome to one and all. I'm Shashank from Gannett, the designated station assistant for the seamless experience of the session. Gannett is very proud to be a digital partner for this event organized by Indian Society of Periodic Nephrology. And the topic of the today's session is approach to hypertension. Gannett is India's most trusted and widely used digital platform with multiple enriching services exclusive for doctors. Let's begin today's session, for which I would like to invite Dr. Jitendra sir. I would like to hand over sir to you. Please proceed with your talk.
Thank you, Sasan. So, good evening, one and all, and I welcome you all to this last session of NEfPRO webinar series. And today's session will be on approach to hypertension in children. Today's session will be moderated by Professor and Head of Pediatrics at All India Institute of Medical Sciences, New Delhi, Professor Arvind Bagga, and Professor Pankaj Hari. Before webinar, we'll have pre-test and link for same I'll be sharing in the chat box. So attendees, you can attempt this thing pre-test from the chat box. So I'm sharing the link for same, and you'll have 10 minutes to attempt that.
Why is there a jam nearby? इससे कुछ विसर्जन का कार्यक्रम होगा. But people are
एक गाड़ी
actually
खराब है
taking
लगता है.
left and people are coming.
So it's already 17 minutes past 7. So we'll begin with the webinar now, and I'll hand over the sessions to today's moderator, Professor Arvind Bagga and Professor Pankaj Hari. Sir, over to you. Hello.
Pankaj, can you introduce Pankaj? Yeah.
Yes. So today we are going to discuss approach to hypertension in children with chronic kidney disease. And for that, we have a very illustrious speaker, Dr. Kirti Sen, who is an associate professor at the Chacha Nehru Bal Chikitsalaya in Delhi. And this will be followed by case scenarios, which will be presented by Dr. Prajal, who is an associate professor at Lady Hardinge Medical College, Kalavati Saran Hospital at Delhi. So over to you, Dr. Bagga, if you want to introduce the topic, so that then we can begin with the presentations.
Thank you, Pankaj. No, I think we'll go on to the speakers, and maybe we can take and discuss questions at the end, So Kirti, could you please begin? Kirti is a very well-known physician and a great pediatric nephrologist. Kirti, we look forward to hearing your talk.
Good evening, sir. Thank you, sir. So I begin with my talk, and that's on hypertension in children. I hope I'm audible. Okay.
Yes, yes. Yeah.
Okay. So is it moving? Okay, so let's first see what's the prevalence, the global prevalence of hypertension in children. So this was a systematic review which included a generally representative sample of healthy children across multiple countries, and they found that overall there was a pooled prevalence of about 4% of hypertension, and another close to 10% had pre-hypertension. And if we see this, I don't know why my slides are not. Okay, so if we see this figure, then we can see that the peak prevalence is usually at 14-15 years of age. And this figure also shows that there has been an increasing trend over the last 2 decades. However, there has not been found to be any difference between gender, that is male versus female, nor any difference between urban versus rural. So what is all this hypertension in children? Is it primary or secondary? So traditionally, we know that secondary hypertension is more common than primary in children. But let us see what the current data shows. So this was data with a large number of children attending a pediatric hypertension clinic. And it was found that among the children who were genuinely hypertensive, around 60% had secondary hypertension, and close to 40% had primary hypertension. So primary hypertension also accounts for a substantial chunk. But if we see the distribution among the age groups, we found that the essential hypertension, the occurrence of essential hypertension increases beyond 5 years of age. So primary hypertension has certain characteristics. That is, usually the child is above 6 years of age. They usually have a positive family history. They may have a high BMI or obese. And usually we find the systolic blood pressures to be high. So coming to the etiology of hypertension. So there are certain predisposing factors, as I said, for primary hypertension. Some are modifiable, like overweight, obesity, the diet, physical activity, etc. And there are some non-modifiable factors, which includes the genetics, the family history, having a low birth weight. And so what causes secondary hypertension? So it's the renal causes which account for the biggest chunk of the causes of secondary hypertension. That is the renal parenchymal and the structural causes, followed by the renovascular causes. And after that, following that, the other causes come in, that is, which could be coarctation of aorta, a lot of endocrine causes, including pheochromocytoma, Cushing's syndrome, then neurofibromatosis, medications, and in a small minority, rarely, it could be monogenic hypertension as well. The CKID study showed that among the children, among around 430 odd children of CKD, there were 14% were hypertensive and another 11% or 10 to 11% were pre-hypertensive. So what is the definition of hypertension that we follow? So the American Academy of Pediatrics came up with their guidelines in 2017, where they gave a cutoff of 95th percentile for age, sex, and height for defining hypertension in children less than 13 years of age. And for those who are more than 13 years of age, they gave a fixed cutoff of 130/80. Further, they said that for stage 1 hypertension, it would be from 95th percentile to 95th percentile plus 12. And beyond that, it would be stage 2. And if we see the European Society of Hypertension, they also follow the same cutoff of 95th percentile, but they take it up to the age of 16 years. Beyond that, they consider a BP of 140/90 as the fixed cutoff for calling it hypertension. And the hypertension guidelines of Canada in 2020 also roughly follow the same cutoff, that is 95th percentile, and the values are almost similar. So the most important thing is to be able to measure the BP correctly. That is, the child whose BP we are measuring should be rested for at least 5 minutes before we take the BP. Preferably, the child should be in a sitting position with his legs uncrossed, his back supported, his arm at the heart level, and we should be applying an appropriate size cuff, and which means that the bladder length should be 80 to 100% of the circumference of the arm, and the width of the bladder should be at least 40%. And it is important that a single BP reading is not always correct. We should repeat BP readings, especially if we find it in the higher range. So now the most contentious issue is which is better, auscultatory or oscillometric method. So oscillometric methods are much in vogue and they are quite easy to use, and so they are becoming very popular. We must remember that oscillometric method measures directly the mean arterial pressure, and it actually uses a proprietary algorithm to calculate the systolic and the diastolic blood pressures from the mean arterial pressure. Now, there have been a number of studies comparing one with the other, which one is better. It has been reasonably proven that the readings with the mercury sphygmomanometer versus the aneroid more or less are highly correlated. But regarding comparison between aneroid and oscillometric, different studies have different results. While the CKID study, it said that oscillometric blood pressure readings are always higher than the auscultatory readings. There were other studies which showed that there was no significant difference. And finally, the systematic review of 2017, comprising more than 25,000 children, they found that though oscillometric may show a higher systolic blood pressure, the diastolic blood pressure was similar. So it is still not clear which one is actually better. So, but we must remember that the pediatric normative data, which has been provided by the American Academy of Pediatrics, are based on auscultatory measurements. So the Academy recommends that the initial blood pressure measurement could be oscillometric or auscultatory. But if the blood pressure is found to be elevated, then we should take 2 additional measurements. And if all the measurements were done by auscultatory, then we could average the 2 and then classify the BP. But if they were taken by oscillometric method and the BP was found to be elevated, then we have to remeasure with auscultatory method, and then it is to be averaged. So now, whom to measure and when to measure? So among all children, the AAP recommends that children who are above 3 years of age, every children should have their blood pressure measured at least annually. And in those children who have underlying diseases like or predisposing factors like obesity, renal disease, diabetes, etc., then of course the blood pressure has to be measured at every health encounter. If we find that the blood pressure is in the elevated blood pressure range, that is between the 90th and 95th percentile, then we are supposed to advise lifestyle modifications, which should continue for about a year before. And if it is still elevated, then we should confirm it with an ambulatory blood pressure measurement. And if it is then found to be elevated, then we go for diagnostic evaluation. If the initial blood pressure was in stage 1, then again we start with the same lifestyle counseling, etc. But we early on, that is by 3 to 4 months, we confirm it with an ABPM and carry on with diagnostic evaluation. So some things about ambulatory blood pressure monitoring. Whatever device is used, it must be validated by these organizations which have been recommended by the society. And by this device, the blood pressure is actually measured over 24 hours. It is set in such a way that the recordings are taken about every 15 to 20 minutes in the daytime and about 20 to 30 minutes during sleep. And there should be at least 1 BP reading every hour. And in 24 hours, there should be about 50 to 60 successful readings. And what it provides, the output is that it gives the mean ambulatory 24 hours BP of systolic and diastolic, as well as the mean of the wake and the sleep periods. Along with that, we can calculate the nocturnal dipping. And these values are then compared with a normative data, which is based on the sex and height. Now, the guidelines of 2022 have continued with the cutoff of 95th percentile for considering ambulatory hypertension for children who are less than 13 years of age. But for those who are above 13 years, they have come up with some values, that is 125/75 for mean 24 hours blood pressure, 130/80 for wake period, and 110/65 for the sleep period, for calling it, that's the cutoff for calling it hypertension. So by the ABPM, we are able to get 4 categories of blood pressure readings. Either the child could be normotensive, that is when the office BP as well as the ABPM both are normal. Or there could be masked hypertension when the office BP was normal, but the ABPM recorded high BPs. Or it could be white coat hypertension, which is just the reverse, that is at office it was high, and while the ABPM records a normal mean blood pressure. And when both record high BPs, then it is sustained hypertension. And these categories, except obviously the normal blood pressure, do have prognostic significance. And it has been found that whether it is sustained hypertension or it is masked hypertension, both have significantly higher chance of having higher left ventricular mass index. And also it has been proven that those who had white coat hypertension confirmed by ABPM, when it was repeated after a median follow-up of 14 months, those children were found, about 61% of them had converted into abnormal ambulatory blood pressures. So that suggests that even white coat hypertension children are to be followed. Now, what about nocturnal hypertension and nocturnal dipping? So these conditions are typically seen in children who have secondary hypertension. And it has been found that even in nephrotic syndrome, about 1/3 of the children had ambulatory hypertension, and of these, about 72% had nocturnal hypertension. And it has been shown in children with CKD that nocturnal hypertension independently predicts the risk of left ventricular hypertrophy, elevated carotid intima media thickness, and pulse wave velocity. Similarly, those with lack of nocturnal dipping or reduced dippers also have a significantly higher risk of cardiovascular morbidity. However, now it has been found that there is no additional value for calculating of BP loads. BP loads give no additional value over the mean blood pressure recording. So now coming to evaluation of a child with hypertension. So the American Academy of Pediatrics recommends that children who are above 6 years of age and show hypertension, there is largely no need for an extensive evaluation for secondary hypertension if the child has a definite family history, if the child is obese, and largely the child does not have any underlying disease or any physical markers of secondary hypertension. However, for all other children, a thorough evaluation must be done, which includes a history and a good physical examination. And the physical examination is actually an exhaustive list. I would just touch upon important things that starting with the vitals. There are many things which give clues to underlying causes. So if a child has a persistent tachycardia, he could be having a pheochromocytoma or even a hyperthyroidism. And needless to say that the pulses are very important to be measured in all 4 limbs. And if there is a decrease in pulses in the lower extremity, then obviously it could suggest coarctation of aorta. A good examination of the facies can show some syndromic features like Williams syndrome, Cushing syndrome, or Turner syndrome, where we know that these are known to have hypertension. Maybe they have a renal artery stenosis or a coarctation or any other causes. Similarly, on the skin, we should look for neurocutaneous markers like cafe au lait spots, adenoma sebaceum, etc., which could suggest neurofibromatosis, tuberous sclerosis, etc. And then coming to all the systems, we should carefully look at them, including the heart, the lung, and then the abdomen. If there's an abdominal mass with a hypertension, it could suggest a Wilms tumor or a neuroblastoma. Bruise, we must check for bruise that could be present in a child having a renal artery stenosis. And of course, if we should look for the genitalia. If there's ambiguous genitalia, it could be a manifestation of congenital adrenal hyperplasia, and so on. Coming to, after the physical examination, what diagnostic lab workup should we do? So for all patients with hypertension, we should carry out a urine analysis to look for the urine sediment, the RBCs, proteins, etc. And a blood chemistry panel, which should include serum electrolytes, the renal function test, lipid profile, and if the urinalysis is abnormal, then, or the renal function is abnormal, one could go for a renal ultrasonography, especially if the child is less than 6 years of age. And then, depending on the secondary cause that we think of, the further panel of investigations are to be done. Like If we think of glomerulonephritis causing the hypertension, then we have to do the ASO titers, ANA, C3, and maybe dsDNA. If we suspect a CKD and a reflux nephropathy, we should go ahead with an ultrasound, of course, and also an MCU or a DMSA. If we suspect renovascular hypertension, then one could go for a Doppler and even better, a digital subtraction angiography. Coarctation of aorta is many times obvious by echocardiography, or we may have to go for an angiography. For endocrine causes, a whole lot of hormonal evaluation, including catecholamines, need to be done. And when a monogenic hypertension is suspected, we go for plasma renin activity, aldosterone, and of course, TTKG, the transtubular potassium gradient for hypokalemia. So whether we should do ECG or echo to understand the effect of hypertension on heart. So it has been found that the ECG is not sensitive enough to pick up left ventricular hypertrophy, and it is recommended to use echocardiography to understand target organ damage, especially when we are considering pharmacological treatment. Regarding renovascular disease, what investigations should be done? So when do we suspect renovascular hypertension? Usually these children present with very high blood pressures, often coming in stage 2, and the diastolic component is usually high. And these hypertensions usually have associated hypokalemia. They may even have hyponatremia. And if the ultrasound shows a size discrepancy of the kidneys, then it may indicate that there is probably a unilateral stenosis, and of course bruits, if they are present, we do suspect. So now we could go ahead with Doppler, but we should remember that Doppler is highly operator dependent and also depends upon the child's cooperation, because he has to hold breath. Then coming to the MR angiography and the CT angio, so both are good, but they have limited intrarenal visualization, so they may miss the segmental stenosis, which may be present in a large number of children. And renal scintigraphy has largely been abandoned because of its low sensitivity. It's the digital subtraction angiography which is now considered the best. It has the best sensitivity and specificity. So the American Academy of Pediatrics, it recommends that Doppler ultrasound should be used for screening of renal artery stenosis only in children above 8 years of age who will cooperate, and they should be having a normal weight. And they have given a grade D recommendation for going ahead with a CT angio or an MR angio. So after the evaluation, coming to the treatment. So what should be our goal? Our goal is to reduce the systolic and diastolic blood pressures to less than 90th percentile. And in a child who's more than 13 years of age, it should be to reduce it below 130/80. So in primary hypertension, the strategies, of course, start with non-pharmacological measures like weight loss, and then the exercise, weight loss, then the DASH diet, that is the dietary approach for stopping hypertension, which includes low fat, less of processed foods, low salt, etc., vigorous activity, etc. And then coming to the pharmacological measurement treatment. So when is pharmacological treatment indicated? So obviously any child who comes with stage 2 hypertension, any child with symptomatic hypertension, children who are asymptomatic with hypertension but have failed lifestyle modification measures, etc., or they already have developed left ventricular hypertrophy, they merit treatment with drugs. And those children who have renal diseases or diabetes mellitus, whatever the stage of hypertension, we go ahead with pharmacological treatment. Now, regarding the choice of antihypertensives, we usually begin with these drugs, that is either the AC inhibitor, the angiotensin receptor blocker, calcium channel blockers, or thiazides. Usually, beta blockers are not recommended as the initial therapy because of its side effects. Regarding hypertension in CKD, both the AAP and KDIGO, they recommend that the goal should be to lower the 24 hours mean arterial pressure to less than the 50th percentile by ABPM. However, KDIGO adds that when ABPM is not available, then a manual auscultatory office BP taken in a proper method can also be used. And with that, we can target a systolic blood pressure of less than 90th percentile for age, sex, and height. And that could be a reasonable approach. And regardless of whatever the office BP is, definitely every child with CKD requires an ABPM at least once yearly to screen for masked hypertension. And these children have to be evaluated for proteinuria, and the drug of choice in these children is AC inhibitor or angiotensin receptor blockers. So what does evidence say? So regarding the use of manual auscultatory method of blood pressure, it was shown by the CKID study that a well-performed auscultatory method of measuring the BP is not inferior to ambulatory systolic BPs, and so one could go ahead with that. And regarding use of enalapril in CKD, this randomized controlled trial found that though enalapril reduces significantly the proteinuria in those who are administered, however, the GFR decline was not different in those who received versus those who did not receive enalapril. Now, coming to the treatment of renovascular hypertension, so one could go with medical therapy alone, or one could go for a percutaneous angioplasty or a surgery. So usually, depending on the percentage of the stenosis, if it is roughly less than 50%, one goes ahead with medical treatment. And if there is bilateral stenosis, then AC inhibitors are contraindicated. In case of unilateral renal artery stenosis, AC inhibitors are the best drug. And if there is stenosis more than 50%, approaching up to 80%, then one should go ahead with revascularization methods. Either it is angioplasty or even invasive surgery. It has been shown in this 11-year retrospective study that though this angioplasty achieves technical success in a large number of patients, more than 90%, but however, the cure of hypertension is not seen in a good number. That is, it is seen in only about 40%. So now coming to acute severe hypertension. So that is hypertensive crisis, and it is of two types. Traditionally, we know that hypertensive emergency is where the BP elevation is associated with life-threatening symptoms, and urgency is where there are no symptoms or minor symptoms. However, the American Academy of Pediatrics does not use the term urgency or emergency. It just uses the term acute severe hypertension for any symptomatic presentation of severe hypertension. And usually these hypertensive crisis is seen in secondary hypertension, most commonly renal causes. And how should we manage? The principle of management is that we should reduce, in the first 8 hours, we should reduce the blood pressure by 25% of the difference between the current systolic and the systolic goal. And what should be the goal? The short-term goal should be around the 95th percentile. And the remaining should be reduced over the next 12 to 24 hours. And it should be remembered that those who had a normal blood pressure just before this episode tolerate reduction, prompt reduction well, rather than those who were already hypertensive. So what are the drugs that should be used in hypertensive emergencies? Usually we go for intravenous drugs, and labetalol and nicardipine are the first line agents that are preferred, followed by hydralazine, and we may also use sodium nitroprusside, though we must remember the potential for cyanide toxicity. In case of urgencies, one could go with oral drugs, which could be either one of any of these. That could be labetalol, hydralazine, nicardipine, clonidine, minoxidil, isradipine, etc., but not nifedipine, because it is difficult to dose it, and also there is a prolonged unpredictable action, and it can lead to severe hypotension. Other calcium channel blockers are too slow for hypertensive urgencies. And now coming to specific disorders, what antihypertensive drug should be used in case of hypertensive crisis. So if the child comes with glomerulonephritis, usually there is sodium and water retention, and so diuretics are good enough. They control the blood pressure to a large extent, and of course they have a component of AKI, so AC inhibitors are contraindicated. Those who have come with AKI, and we could try diuretics, but if there is volume overload and anuria, then of course one has to go for dialysis. In pheochromocytoma, it's the alpha blockers, pentolamine or prazosin, which are to be used first, followed by, after the alpha blockade, the beta blocker may be used. In renovascular hypertension, I've already mentioned that for unilateral stenosis, AC inhibitors are very good. For bilateral, one could go for other drugs like beta blockers or calcium channel blockers. For coarctation of aorta, a gentle BP reduction could be done by using some beta blockers. Coming to a little bit about monogenic hypertension, that this is actually a condition in which there is dysregulated sodium reabsorption at the level of the distal convoluted tubule and the principal cells of the collecting duct. So here, the mineralocorticoid receptor, the ENaC channel, and the NCCT, these are the main players. These are the main channels or receptors which are involved. And so depending on the disease, we have to use agents which block these channels. So like, for example, in apparent mineralocorticoid excess, one should use mineralocorticoid antagonist, that is spironolactone. And for glucocorticoid remediable aldosteronism, glucocorticoids, dexamethasone or prednisolone, it helps. For Liddle syndrome, one could go for triamterene or amiloride. And for Gordon syndrome, the NCCT is involved, so one should go for thiazides. And Gordon syndrome is one case where we get hyperkalemia, unlike the others where we get hypokalemia. And Gordon's also has acidosis, unlike the others which have alkalosis. So I think I've touched upon the important aspects of hypertension within the time that was provided.
Thank you, Kirti, for an excellent presentation. Very nice slides, Kirti. Excellent slides. And we wish we could have given you more time to present, but I think the topic has been covered up very well. And I would now call upon Dr. Prajal to discuss a few cases, and we'll have all the questions at the end, Kirti, so that maybe they could be addressed together. So Dr. Prajal, who's a faculty at Lady Hardinge Medical College, would now be presenting a few patients with hypertension. Prajal.
Thank you, sir. Thank you, sir. So I'll be taking a case discussion on hypertension. I have 3 cases with me today. Depending on how much time we have, I'll go on to discuss first 2 cases, and if we have some time left, I'll go on to discuss the 3rd case. So the first case is a 9-year-old boy who is a resident of Delhi. He came to us with chief complaints of fever since 15 days, vomiting since 7 days, decreased urine output and generalized swelling since 7 days, along with passage of cola-colored urine since 7 days. Fever was recorded up to 101 degree Fahrenheit with no chills or rashes, and it would subside with medication. He had 1 to 2 episodes of vomiting per day, non-projectile in nature. Also, he had decreased frequency and as well as quantity of urine, which was associated with presence of generalized swelling. The swelling began from face and progressed to involve the lower limbs as well as abdomen. Apart from this, he had complaints of passage of cola-colored urine, which was present throughout the stream. It was painless and did not have presence of any clots, suggesting glomerular hematuria. There was no history of recent sore throat infection or upper respiratory tract or skin infections. There was no history of yellowish discoloration of skin, loose motion, or skin rash, oral ulcers, joint pain, or bleeding from any other site. There was no history of altered sensorium or abnormal movement suggesting any encephalopathy. And there was no history of any breathlessness or palpitation. Past history was uneventful. He was a previously healthy child. His development was appropriate for age, had been immunized up to 1.5 years. And there was no no family history of renal disease or family history of passing red-colored or cola-colored urine. He has one sibling, a sister of 11 years old, who is healthy and does not have any symptoms of any disease. On examination, he had a heart rate of 115 per minute with respiratory rate of 20 per minute, no retractions. Blood pressure was 138 by 96 millimeters of mercury, and these were his blood pressure centiles. So clearly, he had stage 2 hypertension. SpO2 was 99% at room air. Hemodynamically stable. CRT was less than 2 seconds. Central and peripheral pulses were well palpable. He had pallor and also had anasarca, periorbital puffiness, ascites, as well as bilateral pitting pedal edema. Systemic examination. The chest was clear. There were no added sounds, no crepitations, no signs of fluid overload. Chest cardiovascular system was normal. There was no murmur. On per abdomen also, there was no organomegaly. Ascites was present. CNS was also appeared to be normal. When we investigated this child, we found that hemoglobin was 4.7, which was very low. PLC was 7,500, and he had thrombocytopenia with a platelet count of 92,000. Urea was very high. It was 221 milligram per deciliter. Creatinine was 5.4, which was also raised with an eGFR of 9.5 ml per minute per 1.73 meters squared. He had hyperkalemia with potassium of 5.1. Albumin was low, 2.3. Cholesterol was normal, 190. Urine routine showed 20 to 40 RBCs with 3+ proteinuria. And urine protein creatinine ratio also showed nephrotic range proteinuria with a value of 6.5. Urine for active sediments were also present. So from these investigations, we can see that he had anemia, thrombocytopenia, AKI with hyperkalemia, low albumin, and evidence of glomerulonephritis in the form of hematuria as well as proteinuria. Liver function tests were more or less normal. On further investigation, we found that serum LDH was also raised. It was 2916. Reticulocyte count was 6.7%. VCT was negative. Peripheral smear for schistocyte was also high. It was 3.4%. Serum C3 and C4 were normal. So, with evidence of anemia, thrombocytopenia, evidence of hemolysis in the form of raised LDH and schistocyte count index more than 2%, and evidence of acute kidney injury, we could make a provisional diagnosis of hemolytic uremic syndrome. In view of fluid overload, which was around 10%, hemodialysis was initiated for this patient with an 8 French hemodialysis catheter and F4 hemodialysis filter. Hypertension was classically difficult to control. Since he had stage 1 hypertension, we had started with him on clonidine. Blood pressure, we had achieved target blood pressure goal in 24 hours with clonidine, which was subsequently increased. It had to be increased to control the blood pressure. And amlodipine, prazosin, and minoxidil also had to be added in incremental doses subsequently to bring down the blood pressure gradually to 90th percentile over a few days. Investigate the cause of HUS. We looked at all the tropical infections. The workup came out to be negative. Blood culture was also sterile. ANA by immunofluorescence was negative. Vitamin B12 was also normal. We did an ultrasound. We found that he had normal kidney sizes, but with evidence of slightly raised cortical erogenicity. On fundus examination, there was no evidence of hypertensive retinopathy. We had also sent anti-factor H levels, which came out to be very high. Normal value is 150 AU per ml, and he had a level of more than 2400 AU per ml. So this was positive. And we could make a diagnosis of atypical hemolytic uremic syndrome. For this, we initiated double volume plasma exchange. We did 6 daily sessions of plasma exchange, following which he had achieved hematological remission. He received a total of 12 sessions of plasmapheresis with 5 sessions of hemodialysis for his renal failure. We had started oral steroids as soon as we had the report of anti-factor H, and after achieving hematological remission, we had started him on IV cyclophosphamide. Currently, he has received two monthly doses of IV cyclophosphamide. So we can see here on this from these investigations that he achieved hematological remission by around day 7 of admission with a normal platelet count of more than 1 lakh, schistocyte index of less than 2%, and serum LDH value less than his upper limit of norm. By 7th day of admission, we were able to get him off hemodialysis. His urine output had improved 1.6 to 1.8 ml per kg per hour. And gradually, by the time of discharge, he had achieved a normal serum creatinine of 0.4 milligram per deciliter, with a platelet count of 1.7 lakh, no schistocytes, and normal LDH. So currently, for this patient, renal functions have normalized. This is the report of last week. His blood urea is 42, serum creatinine is 0.27 mg per deciliter, potassium is 4.1. Urine output is currently maintained between 1.6 to 2 ml per kg per hour. Although he still has some persistent edema as well as proteinuria, but serum albumin seems to be normal. We also did a 2D echo for him to look for cause of edema. Came out to be normal. As for his hypertension, he needs 5 antihypertensive agents as of today, which includes amlodipine, prazosin, minoxidil, labetalol, as well as chlorine. We did give a trial of AC inhibitor after his renal functions had normalized, but his renal functions worsened as soon as we started put him on NEfPRO. And when we stopped the NEfPRO after 2 days, his renal functions came back to normal. So we could not continue NEfPRO for now. Further on, for immunosuppression, we have planned to taper the dose of steroid and complete 5 monthly doses of cyclophosphamide, followed by maintenance immunosuppression in the form of mycophenolate morphine. This is the second case. This is a 3-year-old boy who is a resident of Faridabad. He came to us with complaints of progressive pallor for 1 year, fever of 2 days, cough of 2 days, and shortness of breath for 1 day. Fever again documented up to 101 to 102 degrees Fahrenheit. Cough was productive, no renal variation. There was no history of cardiac involvement, form of bluish discoloration of eyes, no jaundice, pain abdomen, vomiting, or rash. No history of bleeding from any side, prior history of blood transfusion, no history of renal involvement as per the history, reduced urine output, red colored urine, generalized swelling, or recurrent fever without focus. Past history was uneventful. Development was appropriate for age. Was immunized up to 101.5 years. And there was no family history of renal disease. This was a non-consanguineous marriage. And there are no siblings and no sibling death. And no history of any abortions. On examination, he had a heart rate of 155 per minute, respiratory rate of 40 per minute, some intercostal retractions and nasal flaring mild was present. Blood pressure was 114 by 72 millimeters of mercury, so which was between 95 to 95 plus 12 centimes. So he had stage 1 hypertension. SpO2 was 99%, but with oxygen biomass at 6 liters per minute. CRT was less than 2 seconds. Central peripheral pulses were well felt. Pallor was present. And he had periorbital puffiness with bilateral pitting pedal edema. Also had short stature. On respiratory examination, there was some fine creps, occasional in bilateral basal areas of chest. Cardiovascular examination was normal. He had ascites on per abdomen examination. CNS examination was normal. When we investigated him, we found hemoglobin of 6.5, which was low. Total count of 10,000 and platelet count of 2.5 lakh. CRP was raised, it was 34. He had a urea of 180, it was high. Creatinine of 3.3 milligram per deciliter with an eGFR of 11 ml per minute per 1.73 meters square. Slight hyperkalemia with potassium of 4.9. Borderline low albumin of 3. Cholesterol was 199. Urine routine showed 2 plus protein and RBCs of 9, but no active sediments. Urine protein creatinine ratio showed subnephrotic proteinuria, which was 1. Blood culture was sterile. ANA was negative. On further evaluation, we found that he had low calcium of 7.8, phosphorus was 5.5, slightly raised for age, ALP slightly raised for age 5 and 4, had some amount of metabolic acidosis with a bicarb of 15. Liver function test seemed to be normal. Fundus examination was normal. This was his chest X-ray. This is a slightly rotated film, so I cannot really comment on cardiomegaly. But he has some infiltrates, perihilar infiltrates in the right lung field. So we made a provisional diagnosis of either acute kidney injury presenting as sepsis with pneumonia, or he may have a chronic kidney disease in view of prolonged pallor, short stature, and profound weak. On day 1 of admission, we started peritoneal dialysis with Tenkoff catheter in view of fluid overload, put him on IV antibiotics, as well as antihypertensive drugs. Since he had stage 1 hypertension, we could control his hypertension with three antihypertensive agents. Relevant investigations were sent for chronic kidney disease as well. On day 7 of admission, he had an episode of generalized tonic-clonic seizures with bradycardia, requiring bag and mask ventilation. It was attributed to hypocalcemia. Blood pressure was under control with antihypertensive agents at this time. At this time, he had to be intubated and put on mechanical ventilation. HP was also low, 6.1, below the target for patients on mechanical ventilation. So we had to give him 1 packed cell transfusion as well. By day 14 of admission, he developed PD peritonitis with a PD cell count of 178, with a total count of 178 and 85% polymorphs. And he also had some flow issues, outflow problems. So oliguria also persisted at this time. Urea creatinine was still high. So we had to switch him to hemodialysis and PD catheter was removed. Further investigations showed low vitamin D, 15 nanogram per ml, with a high PPH of over 9. Serum iron, ferritin, and transferrin saturation were also reduced. B12 and vitamin B12 and folate seemed to be normal. On T2D echocardiography, he had evidence of LV hypertrophy. Ejection fraction was normal. This was his ultrasound, which showed small sized kidneys, 5.6 into 2.4 centimeters. Even left kidney was small. We can see that we can hardly make out any differentiation between cortex and medulla. There is no differentiation between cortex and medulla, and the cortical echogenicity seems to be raised. So at this time, we could formulate a diagnosis of chronic kidney disease in view of a long history of pallor, short stature, hyperparathyroidism, as well as hypoplastic kidney. Along with that, he had symptoms of fluid overload, anemia, hypertension, stage 1, chronic kidney disease, mineral bone disease. He also had undernutrition and pneumonia. To delineate the cause of ultrasound CKD, we did an ultrasound renal Doppler also, which was normal. MCU was also done, which was also normal. So by day 18 of admission, we could extubate him. Supplemental oxygen was weaned off. Vitamin D and calcium supplementation were given. This patient was discharged by day 25 of admission with the blood pressure between 50 to 90th centile on requiring 3 antihypertensive agents. Hemodialysis was continued with right IGV hemodialysis catheter. At the time of discharge, he had hemoglobin of 8.2, CRP of 0.5, urea of 112, creatinine of 2.1. No hyperkalemia, albumin was 3.2, and no metabolic acidity. So we could classify him into chronic kidney disease, stage 5D with hypertension. He has been on maintenance hemodialysis thrice a week for 1 year and 2 months. We did counsel him for renal replacement therapy in the form of renal transplantation. However, we have not been able to convince him for that yet. And he's still continuing thrice a week hemodialysis. Urine output is only 100 and 150 ml per day. Still has some amount of protein urea, but no edema, and blood pressure is controlled on 2 antihypertensive agents. So current investigations, he has hemoglobin of 10.8 with a creatinine of 2.5, no hyperkalemia. CKD MBD parameters are within normal range and no metabolic acidosis. Sir, do I have time to move on to case 3 or should I stop?
There are a number of questions, Prajal, and perhaps, we could, if Dr. Pankaj feels okay, Pankaj, can we move on to the questions?
Okay, sir.
Pankaj, are you okay with it?
Yes, sir. I think we can take the questions.
Yeah. I think because I think
have
yeah,
more
absolutely.
discussion. Yes.
Okay, sir.
So Pankaj, could you please take over the questions? Maybe just discuss them maybe one by one. Whatever.
Okay. So there is one question for you, Prajal, or rather, Kirti can take this question. Why is 95 plus 12 centile specifically used as a cutoff for hypertension in children?
Why it is used 95 plus 12 is used for as a cutoff for stage 2 hypertension. It's a classification. So beyond 95th percentile, it's stage 1, and 95 up to 95 plus 12, it is stage 1, and beyond that, it is stage 2. And probably this is based on normative studies on children and which have been done earlier. The origin of the cutoff, I'm not aware.
Okay, so I can tell you the genesis of this, because previously it used to be 95th centile, and then the severe hypertension was classified as 99th centile. Now, in fact, the distinction between the 95th and 99th percentile used to be very small, just about 2-3 millimeters. So to clearly define children who had very severe hypertension from the ones who were having moderate hypertension, it was decided to have a 12 millimeter addition to the 95th percentile, so it be very clearly above a particular above the stage 1 hypertension, and to be easily classified as severe or stage 2 hypertension. That's the reason. Okay, then there is another question that when do you consider going for DSA instead of non-invasive angiography methods? And I think you did discuss something about the angiography, Dr. Kirti, and could you just answer this question?
Yes, so non-invasive angiography would mean Doppler. And if many times Doppler is not able to see the intrarenal vessels well, and also when the child is not cooperative, the Doppler is not that sensitive enough. And so when we have a high suspicion of renal artery stenosis, there is hypokalemia, a size of one side of the kidney is small, and the BPs are really high, not controlled by 2 or 3 antihypertensives, and Doppler is unable to delineate the stenosis, one should go for DSA.
Okay, so just to add that Doppler isn't a very good method in very young children, less than 6 years of age, and so therefore, in younger children, you can use CT angio and MR angiography also in these subgroup of children where you suspect a renovascular hypertension. However, whenever your indication is very likely to be there, then you could straight away go ahead and do a DSA. Very often we end up doing a CT angio, particularly when you're suspecting a Takayasu arthritis, when you're trying to look at the wall edema, etc. So you end up doing 2 investigations. I know it adds to the radiation, but then intervention specifically, you'll have to do a DSA, but for diagnosis, even the other methods like CT angio and MR angio can be done. Bhaga, would you like to add anything?
Well, I would agree with you. So the sensitivity of DSA is clearly higher, and particularly things like fibromuscular dysplasia, etc. So clearly, so the anatomy is much better, and obviously, as Pankaj just said, especially when you're planning to do angioplasty simultaneously, so you can with one procedure you can perhaps go ahead. Yeah, especially if you think that there is renovascular hypertension based on say clinical features. So suppose you do get a bruit, and the patient is markedly hypertensive, I would perhaps go ahead and do a DSA because one could confirm the bruit, and if the radiologist is confident enough, one could then go ahead and do angioplasty at the same sitting. But this would vary from center to center.
Okay, then there's a question for you, Prajal. How do we advise for home blood pressure measurement in clinical practice?
So for home blood pressure, what we do is that we need to first tell them to get the appropriate sized BP cuff, which is very essential, and which are not very easily available. Yes, but this is an important thing, that the cuff that they're using to measure the blood pressure has to be of normal size. Definitely, using an auscultatory method for at home will not be feasible for parents. So an oscillometric method would be better for them, using an appropriate size BP cuff. What they can do is, whatever antihypertensive drugs they are on, whatever number they are on, what we usually do is we ask them to maintain a record of blood pressure prior to giving that antihypertensive drug. And we also tell them the target of blood pressure, below which they are not supposed to give antihypertensive agent. So these are the 2 things that we must remember, because we don't want our patient to be undertreated or overtreated at home, because they will not be able to manage the emergency. And we need to provide them the appropriate size cuff and maintain a BP record, and review with us in 2 weeks' time or 3 weeks' time to look at the control of blood pressure and advise appropriate modification.
So if I may add to this, when you do home blood pressure monitoring, the American Academy of Pediatrics guidelines, they very clearly mention that the blood pressures have to be recorded continuously for a period of a week, both morning and evening. You should be using the appropriate, as you said, BP cuff, and also the appropriate validated instrument, which is sometimes very difficult to procure because the instrument should also be validated in children. And so the home BTB monitoring is just more like for control of hypertension and for diagnosis of hypertension, but would still rely on clinic blood pressure, auscultatory, and even we now know the guidelines say that ideally, if you're suspecting a primary hypertension, you should be doing the ambulatory blood pressure monitoring for confirming the diagnosis, because it also helps you exclude white coat hypertension and others. So there is a question, say, which is asking the CKD ACE inhibitor drug of choice. So I don't understand clearly what they mean, the type of which ACE inhibitor, or is it the drug of choice for CKD? Can you answer this question, Kirti?
Yeah, so in CKD, there is RAS activation, and that is a major cause of hypertension. So as long as the creatinine is, say, below 3, we definitely AC inhibitors are recommended.
Yes, and particularly if there is a proteinuric CKD, then ACE inhibitors should be given because it has both the effects of both reducing proteinuria as well as high blood pressure. And there's a question, Prajul, for you. If first 8-hour goal should be by MAP or the systolic blood pressure. I think it's the meaning. It's meaning the hypertensive emergency.
In hypertensive emergency, again, as per the guidelines, we have to take the systolic blood pressure, and we take the target is 95th percentile in the first 8 hours. So the difference of the systolic blood pressure and the 95th percentile, we need to take that difference, and 25% of that difference has to be reduced within the first 8 hours.
Okay, will you like to add something, Kirti?
So actually, the guidelines, they don't specify whether it is systolic or it is mean arterial. They just say that 25% of the planned reduction for in the first 8 hours. So I would suggest if we reduce, if we consider the systolic blood pressure reduction, then we would ultimately be reducing the MAP as well, I think. So generally, it is the systolic blood pressure that we aim at.
Yeah, in some of the guidelines would also mention the MAP also. Okay, so is nitroprusside contraindicated in CKD? This is a question to you, Kirti.
So no, nitroprusside, yes, it is contraindicated in CKD. Nitroprusside should not be given because it would lead to cyanide toxicity. Is that what we meant?
Yeah, but I think not all CKDs will have accumulation of nitroprusside. So I would say
we
that
cautious, basically. Yeah.
Yes, if it is getting prolonged, and particularly somebody who's on dialysis, you could still use it. But if you're not able to get the BP control and the nitroprusside is going on beyond 72 hours, that you'll be worried about. But otherwise, there is no contraindication as such to use nitroprusside. Maybe Dr. Bagga can also comment.
Yeah, I would agree, and so especially if they're on dialysis, then it's not an issue. There are some guidelines, Kirti, I'm sure you have read, that there are some people who would say that B12 देने से कुछ फायदा होता है, the thiocyanate toxicity in CKD, but I don't think we really have protocols on B12. For some reason, B12 works, or it helps. But I would agree with Pankaj, that generally if it's a CKD and you have to use nitroprusside, we are quite okay using it, and within 72 hours anyway, your blood pressure values are okay, and so yeah, it's not really an issue. Yeah. Okay.
There's another question in refractory hypertensive emergency. When you're not able to reach the 8-hour target, how do you go about? So, Kirti, would you like to answer this question?
Yeah, so usually we plot a graph, and when we start the infusion and we monitor it, then the expected versus the measured, we keep titrating. And when we find that we are the line in the graph is not going as per expected, then it is then that we should increase the rate of infusion. I think if we do that diligently by repeated monitoring and all, we aim to proceed along that line, and we should be able to get it by 8 hours. And if we cannot, then we I think we should continue with those drugs and achieve that 25% reduction. I don't know whether to define any time period within which we should do it. I think, sir, you could.
So finally, you would need to increase the dose of the infusion in case if the blood pressure is not getting controlled. So, and if you're not, if you're seeing that your trajectory is such that your blood pressure is not getting controlled, then you have to increase the dose. There is a question about asking about what is BP load? Can you explain?
Yeah, so in ambulatory blood pressures, this term is used. That is the number of the blood pressures which are above the 95th percentile, the percentage of recordings which are above the 95th percentile, that is called BP load. So, however, now it has been found that calculating BP load does not give any additional information beyond what just getting the mean ambulatory blood pressure.
Okay. Any preference of labetalol versus nitroprusside for treating emergency and injectable?
Yes. So labetalol is usually preferred because of those side effects of nitroprusside. And but of course, if the child has, but there are some contraindication for labetalol as well, like if the child has asthma or the child, young neonates and infants, usually labetalol is not chosen. I think.
Okay, there is a question for Prajal. This is a newly diagnosed case of hypertension. You have advised lifestyle modification for 3 to 6 months, and then you are supposed to assess by ambulatory blood pressure monitoring. Now, does this apply for all these stages of hypertension, or is it only for stage 1 hypertension?
They're trying to ask, when do we do ABPM, right, sir?
No. They're saying this kind of a thing that you will go ahead with lifestyle modification. So in many ways, what the person is trying to ask that where are the situations where you will also go for pharmacotherapy and not wait for just the lifestyle modification for 3 to 6 months.
Okay.
It is generally done for stage 1 hypertension.
Okay. So I think this was covered by ma'am. She had told us that cases where we have to do indications of pharmacotherapy are clearly stage 2 hypertension with when in the presence of non-modifiable risk factors, or asymptomatic hypertension. Sorry, asymptomatic hypertension, but with failure of lifestyle modification, as well as symptomatic hypertension. And in cases who have CKD or diabetes mellitus. These are the indications where we would also give pharmacotherapy.
Okay. There is a question which is little unrelated. Increased echogenicity is of any significance in managing any child with acute or chronic kidney disease. The appearance on ultrasound doesn't help us in the management, but yes, it does help us in trying to figure out whether the child is having an underlying chronic kidney disease, because then the echogenicity is generally increased. There's a question for you, Kirti. How do you diagnose GR, glucocorticoid remediable hypertension?
Okay, so this is a type of monogenic hypertension. Initially, the lab reports would tend to show hypokalemia, and then what we should do is basically we get a cortisol to cortisone ratio which is high, which clinches the diagnosis of GRA. Because this is a condition in which the 11-beta hydroxysteroid dehydrogenase does not convert cortisol to cortisone, and it acts on the mineralocorticoid receptor. So the confirmatory diagnosis is by that, the ratio.
Okay, Prajal, there's a question related to your second case that amlodipine was used for hypertension control. Child also had proteinuria, and amlodipine is known to worsen proteinuria. So should it be given in CKD?
So as per our guidelines, AAP guidelines, the first 3 choice of antihypertensive agents are, even including CKD, are either ACE inhibitors or calcium channel blockers or thiazide diuretics. once any of the two, if there is a failure of any of the above two antihypertensive agents, then we can go on for other antihypertensive agents, including alpha blocker, alpha agonists, or alpha beta blockers. So protein, I don't think that amlodipine causing proteinuria is very significant. There have been studies on it, and some studies did show, but ultimately it was found that calcium channel blockers have really no effect on protein. Sir, is that?
Yeah, so correct. I think I mean, if you have to choose an antihypertensive agent in CKD, ACE inhibitor would be a good choice, unless until there is any contraindication like a very severe, severely low GFR, you can always use amlodipine. So, Kirti, there's a question for you. The CKD child is also having short stature, and so do BP will have to be classified as per the child height?
Yes, for BP classification, we do take into account the height of the child. The AAP normative data, it has gender, height. According to that only we find out the percentile of the child and we check the BP.
Right. So the stature, the current height of even a CKD child will also have to be taken into consideration, and you don't have to use any other height or normal height for that particular age, etc. Any guidelines about neonatal and infantile hypertension? How to diagnose? This is a question for you, Kirti.
So for neonatal and infantile, I think the AAP recommends that the fourth report is to be continued. The fourth report of the AAP, it stands good even today for these two sections of children.
There's a question about hypertensive crisis in an infant who also has a spontaneous DVT, and the question is that do we consider doing a CT angio to rule out renal artery thrombosis? Rajal, would you like to answer this question?
CT angio. Again, for renal artery stenosis, for renal artery stenosis, Doppler in this child will not be a very good modality, definitely. CT angio, yes, maybe we can do it, but again, as ma'am has said, that there is limited. There will be limitations. We will not be able to see all the renal vessels. I guess after stabilization of the hypertensive crisis episode, if we are really suspecting renal artery stenosis, we should go ahead with TS.
Yeah, so CT angio can be done if you're suspecting renal artery thrombosis in an infant, because it's a less invasive method than DSA, and for diagnosing, you can do it. Can we directly proceed to do ABPM if office BP on multiple visit in stage 1 hypertension, or wait for 3 months of lifestyle modification? So can you answer this question? Yeah.
Yeah, so if there are no underlying causes of secondary hypertension and the child is otherwise healthy and he was just incidentally detected with a stage 1 hypertension, then we are to advise lifestyle modification, diet, etc. for a period of 3 months, and maybe it normalizes after that. So only after 3 months, if it is still elevated despite these measures, then we should go for ABPM and diagnostic evaluation.
Right. And there's the last question for you. What is the significance of nocturnal hypertension and dipping? This is in context with the of EBPM.
I think I did mention that in my slides as well, that nocturnal hypertension has a bad prognosis, and it is an independent predictor of cardiovascular morbidity, and similar with absence of nocturnal dipping.
Good, thank you, Kirti, for answering these questions, and Rajal. And now, sir, would you like to make any comment, or do we hand it over to Jitendra for the rest?
I think Jitendra, I think it's an excellent overall discussion, and well answered questions, and very nice slides. Jitendra, I think you should, perhaps we could go ahead. You know, we are already kind of exceeding our time.
Thank you both, sirs, Dr. Kirti, Dr. Prajal. Now we'll have the post-test. Sasank, can you begin with the post-test, please?
Yes, sir. I'm doing it right now. I'm launching the first roll.
Okay.
20 seconds left. Ten seconds left. And the first pole.
Back.
Launching the second pole. 20 seconds left. Ten seconds left. End of second pole. Launching the third one. Twenty seconds left. Ten seconds left. Ending the third one. Launching the fourth one. Twenty seconds left. Ten seconds left. End of fourth question. Launching the fifth one. Fifteen seconds left. Five seconds left. And the push. Now launching the next one. Twenty seconds left. Ten seconds left. End of question 6. Launching the seventh one. Twenty seconds left. Ten seconds left. End of the seventh one. Launching the eighth pole. 15 seconds left. Five seconds left. End of question 4. Launching the 9th one. Fifteen seconds left. 5 seconds left. End of question 9. Launching the last one. Twenty seconds left. Ten seconds left. End of the last question. Thank you, everyone.
Thank you, Sasank. And that brings us to the end of the NEfPRO webinar series. So today was the last session we had on approach to hypertension. And thank you, participants, for joining us throughout this webinar series. I hope it was useful for you people, and continue. You can continue to watch these videos, and these resources will be helpful for you in future as well. And I would like to again thank you all the faculties across the India who has contributed to this webinar series. Baga sir, you would like to say some
Yeah, yes, I do want to. Yeah, I do want to. And I think it's, thank you so much, Jitendra, Aditi, and the entire organization behind in fact, Learnet, who have worked in tandem under the overarching umbrella of the Indian Society of Pediatric Nephrology for doing this major academic activity. It has been almost like a marathon that has gone on for months together, and we have really gone through various modules. And at the end, we had this very important talk, which is perhaps, save the best for the last, And I would really like to thank all our faculty during the entire year who were involved in this, and obviously with a lot of help with the kind of leading the entire endeavor with Jitendra and Aditi and the entire organization, Susan, Dr. Kanitkar, Dr. Arpana Iyengar, Dr. Uma Ali. I think I would be missing a lot of names, but I think we owe it to all of them to making this thing a success. Thank you so much once again, Jitendra.
Thank you, sir. It would not have been possible without your guiding us throughout this webinar series. And for participants, we'll be having one final brief session on 2nd of October in evening at particularly at same time to announce the awards related to this webinar series. For quiz and for attendance, so we'll have brief ceremony on 2nd of October. So I hope that you would join us for that day to conclude this 6-month marathon academic activity. Thank you, sir, once again for your all efforts and your all time you have given us for guiding this webinar series.
Thank you.
Aditi ma'am.
Hi, good evening. Thank you, Jitendra, and thank you, sir. I think we must bring it to the attention of our delegates that we decided to coincide the end of this series with the superannuation of Professor Bagga, who would be moving on to another phase of his life tomorrow. So he'll be, we are grateful to him for the support he has provided for this entire webinar series. And it was his mentorship and guidance that has caused this webinar to be these webinars to be implemented. implemented and carried out in this manner. So he has constantly watched over it. He has made sure that corrections happen, the right topics are chosen, the right speakers are there, and we are really grateful for your support, sir. And I also take the occasion to thank Professor Pankaj Hari, who is the academic committee chair of the Indian Society of Pediatric Nephrology. And sir, without your guidance and support, this series would not have been possible. So if Pankaj sir is probably not here, let me see him now.
Sir has left.
Okay.
probably
Okay.
with
Okay.
Vijay.
Okay. So thank you. And we would like to meet with all delegates separately. On the second, we would try to just do a small felicitation of those who have graduated from the series with good attendance and also hear feedback. We know that there have been many glitches and many issues with this first round of webinars, and we hope to rectify and remedy the problems. And once again, like sir, I would like to thank the ClearNet agency and all the members of it for supporting us through this challenging task of carrying out weekly webinars with limited support. Otherwise, I mean, without your support, it would just not have been possible. Thank you.
Thank you so much, ma'am. Thank you so
Thank
much.
you, Jitendra, for implementing all this. Thank you, Jitendra. I know that you are behind it all, so thanks.
Thank you so much, ma'am. And thank you, everyone. If all would be requested, like if I go ahead and take your permission, can I conclude the session over here?
Yeah.
Thank you. Thank you, everyone.
Thank you. Good night, everyone.
Good night, sir.
Thank you.